Hi, I'm Dr. Michael Reiner, your host of the Independent Doctors of Pahrump, a TV show that airs Monday night on Channel 46. I want to remind you that I am a practicing physician in Pahrump, and I'm an independent practitioner, which means I am not bought by any insurance company or corporate medicine. We provide the highest level of care. We have nurse practitioners. We have other physicians, specialists who come to our office. Please come visit me. I'm at 1316 East Calvada here in the heart of Pahrump. Thank you. All righty, we have Chuck on the phone. Chuck, thanks for calling.
Hey, Doc, welcome back. Great to have you.
Thank you.
I loved what you said about people taking responsibility for their health, finances, and everything else. And if we ever wake up, we might get our country back.
Boy.
But anyway, regarding diabetes, a friend of mine passed away in 2008, had severe diabetes. And he had this diabetic neuropathy. And for years, was in extreme pain, and then finally Dr. Topo, that used to work at the VA, put him on gabapentin, and it really helped him out tremendously. And you mentioned GABA as being part of the chemicals of the brain, and I was just wondering if you could explain a little bit how that works with the neuropathy.
Okay. I will. Neurontin is not GABA. Neurontin is gabapentin, but it's not related to that particular neurotransmitter. But it originally was designed as an anti-epileptic drug, and of course it became not. It wasn't that good at being an anti-epileptic drug, but it seemed to slow the brain down enough to basically modify ascending pain fibers. So, it basically worked at that particular level to help alter your sensation to that neuropathic pain. And neuropathic pain, unfortunately, comes in a lot of different flavors. And diabetes is just one cause of neuropathic pain. Shingles could be another one. Postherpetic neuralgia, where you actually burn the nerves through a viral infection and they're irritated and they're constantly discharging. But what happens with the nerve is not necessarily dead, but it's not necessarily alive. So it's getting enough blood flow and it's misfiring, and it doesn't interpret the signals, and that's what's basically causing a lot of the pain and the burning, because a dead nerve is a numb nerve. It just basically is done, and so therefore you actually have numbness. It's the searing, burning portion of a nerve that's trying to die that is where you get the neuropathy from. One of the mistakes out there that's being made with gabapentin or Neurontin is it also helps with chronic headaches too a little bit, is that it does cause weight gain, and that's not necessarily a good thing for a diabetic. But I see a lot of patients on really high dose Neurontin. I mean, 800 3 times a day, 600 4 times a day, 3,000, that's actually pretty high, but 2,400, 1,800 milligrams. And that's actually is someone that really doesn't understand that particular medication. 300 milligrams is probably going to work as good as 600, but no more than that. Meaning this drug does not have a dose-dependent effect. The more you prescribe, you will not get increasing effects. And then they came out with a new drug called pregabalin, which is a form of a neurotransmitter, and it's called Lyrica. Now, Lyrica is actually a dose-dependent drug. The more you give, the better the effects of that particular medication. So if your doctor has you on 1,800 to 2,000 milligrams of gabapentin, my suggestion is you cut back on that because you have exceeded the benefits of what that medication can do. 300 to 600 is probably going to work as good as that particular dose, and you may not gain as much weight. And if you're not getting a response to 300 to 600 of gabapentin, you might consider Lyrica to get thing. Amitriptyline was one of the old standby medications for neuropathic pain. There are some other drugs like Savella, and what they've learned is that basically the ascending pain fibers, basically, you basically are hitting them on multiple levels, just like you're treating diabetes on multiple levels. SGL2 for your kidneys, metformin to block the insulin surges, the drugs like Tradjenta, those GPP4 inhibitors to basically help stabilize your blood sugar after eating, the insulin. So you have to use multiple levels of medication sometimes to get tight control, as well as you have to use multiple medications in control of pain. As I've said before, methadone is an opioid, but it actually is very, very good for neuropathic pain and just about any other pain that you have. It just has a big negative connotation with it. I mean, if I walk into a room and tell somebody I'm going to put them on methadone, they're basically going to say, oh, that's for heroin addicts. And they say, well, yeah, that's true. There are a few heroin people that are withdrawing from methadone. It's because it lasts a long time and it helps to fight the pain of withdrawal. So that's why it's so effective in that, but it's also very effective in neuropathic pain. So I hope that answers your question about gabapentin, why it does work. It works very well for some people, but if it doesn't, you might want to think about Lyrica. And again, microvascular diseases of the nerve are very important. So, Ray.
Yeah, Doc, some of the things you talked about, I'm familiar with. Glaucoma, I've got glaucoma, and I find got to keep my pressure at a certain level. And there's what they call an average, which I wasn't really aware of until last time I saw Dr. Leaks, where sometimes you think it's high, but the average means like the center, and you may be a little bit above it or a little bit below it.
Right.
And I think the average that's what it's supposed to be. Shouldn't be 16 or 18. It should be 15. That's the average. And actually, there's a little leeway in there, and I didn't understand that. Also, the detached retina, I had one of those. And if anybody gets flashes, if they see flashes, especially when they're going to sleep, they ought to see an eye doctor because it's probably a retina that's starting to pull apart, and maybe they can save it before that. There's ways of laser treatment where they can not operate on you, but actually save it from becoming detached.
Yes, and they can basically tack down the margin of the expansion, hopefully to slow it down. And sometimes on larger ones, they'll do an operative procedure called a buckle, where they actually go in there and try and tighten it down. So yeah,
that's what I had. I've got the buckle in my eye till today. I've got it for 17 years now.
Yeah.
But on one of your previous shows, or one of the reruns I saw, something that's interesting, and I want to bring it up again. A lady named Diana, and said about her mother being out of pain medications, was really suffering, and she got into medical use of marijuana, and now she uses no pain pills. So if you could just talk on that a little bit, I'd appreciate it, because this is something people really should know. Because the oxys and the hydrocodones and that are really not good for you, and this medical use may be something that people have to look into.
Yep.
You've got a real good show tonight. I'll let you finish up, and thank you so much for being there.
That's a good topic. I mean, I sometimes don't like to hammer it too hard because I think it gets old. But Dorothy is a patient of mine, and one of those people who was kind of anti drugs of any type, and somehow decided that medical use of marijuana. She has some COPD and some other conditions, and basically, she got the use card and was able to get off a lot of her pain medications, almost all of them, using a vapor oil type situation, which she couldn't smoke. I've been impressed by the number of people that have actually been able to get off of a lot of their pain medication, or at least modify that. Not a lot of studies have been done, but marijuana, like every other pain medicine, might, it does calm you down a lot. So if it does reduce the nervous inputs or the transmission rate of some of these, and I'm talking out my rear because I don't know this, but based on everything else I know about certain pain medications and what marijuana can potentially do, it can slow down some of those nervous input. And in doing so may actually, I mean, let's look at it. I mean, one of the bigger indications for marijuana is seizure control, and especially in young children. And why is that? So gabapentin does that too. Neurontin does that. I mean, there are a lot of drugs. Dilantin does that. What are they doing? They're slowing brain transmission rates. They're slowing nervous impulses. And sometimes they hit just the right impulses in some area to modify pain, or they modify the seizure control. And they do that. So it does have that benefit. Now, one of the side effects, obviously, it may slow some mentation in other areas. And it does, in my mind, interfere with short-term memory. And sometimes it's very hard because you're not, if you're trying to concentrate, you may think you're remembering things, but you actually are not. So there are some side effects, but at that particular point, if your life is unmanageable because of pain, and the pharmacies in town are being what I call, and I don't mind saying it, they're just when they don't want to fill patients' prescriptions and they want to order X amount of medications, you know, and I don't care. I write prescriptions all day long, but I mean, they're just jerks when they don't want to fill patients' prescriptions that have been on a long period of time because they're afraid of the big bad DEA. And once I get on my soapbox, I can't stop. But you know, they just, I mean, it's someone in corporate. It's not actually the pharmacist here in town, and I don't want you to think that they're in control. No, it is some that sits up in the corporate level that heard about the Walgreens bust several years ago and has decided that the best way to protect themselves from the DEA is never increase your numbers, never go over a certain threshold, and they'll never come in and fine you because they're not busy doing their due diligence. But then they got the audacity to call me and ask for records on a patient that they wouldn't know how to interpret. So, you know, medical use of marijuana, you know, if you have chronic pain, if you have chronic headaches, if you have anything that is chronic that requires medication, may be a viable alternative for you. And I encourage you to read about it, to talk to people, to you know, if I say experiment, I'm not going to tell you to do that, but you know, if you did, then that's just what you do. You know, to find out whether or not you're going to get some relief from this condition. And like I said, you know, 40-something thousand people died from opioid overdose in 2010, and that number is probably going up over and over again. It might be decreasing as it becomes harder to get this stuff, but you know, thank God that the states have allowed this to happen, even if it's for tax revenue. Who gives a crap? I mean, the bottom line is they got something out there that might be able to help you, and I encourage you you know, to think about that as a viable option for people, and erase it in drug courts and see all the things that are happening and the detrimental things that people do. And I know, you know, people like to zone out and whatever, you know, drugs seem to be the answer. But for those in chronic pain, having to deal with pharmacies and regulations, you might want to consider marijuana as an alternative. So with that, we're going to conclude the show. Thank you for tuning in tonight, and we'll see you next Monday night. Thank you.